So we're here in Chicago, in North Shore Hospital, and we came today to work with Mark Metzl to work on practicing the protocol of identifying non-PV triggers in patients with persistent atrial fibrillation. We started the procedure by cardioverting into sinus rhythm, creating maps of the right and left atrium. So we splay the catheters around the left and right atrium. Usually we put one multi-electrode catheter in the right veins and one in the left veins if it's before PVI. If it's after the PVI, so and the veins are isolated, we put the two left-sided catheters on the posterior wall and on the septum. So we have enough electrodes in this chamber. We have another decapolar catheter in the coronary sinus, and the fourth one, decapolar catheter in the crista terminalis. So we have multiple electrodes in both chambers. Then we start the stimulation protocol, and we make sure that the blood pressure is stable. We communicate with the anesthesiologist, as Mark was doing throughout the case, and as we increase the dose of neo to support the blood pressure, we start infusion of isoproterenol, and we started a low dose of between 2 and 3 micrograms per minute, and we escalate this dose to up to 30 micrograms per minute over 10 minutes or so, as long as the blood pressure permits, or junctional rhythm occurs. If junctional rhythm occurs, we stop the isoprel. Usually throughout this escalation of dose, we're going to see atrial premature contractions, APCs. We are really interested in those that initiate atrial fibrillation. Usually they will occur throughout like this stimulation. If they don't, then we also add adenosine bolus at the peak infusion of isoprel. Now usually the dose of adenosine is 6 to 12 milligrams when patients are not on isoprel. However, when they are so sympathetically driven like or being on isoprel, we need to use much higher doses. When we do that, it potentiates the effect of isoprel, and it can also help identify triggers that are mostly vaguely mediated, like in patients that develop AF in the middle of the night or after exercise, so different kind of triggers. At the peak dose of isoprel infusion, we paste the heart from the coronary sinus into atrial fibrillation and then shock the patient back to normal rhythm on isoprel. The idea behind this is that you reduce the threshold for fibrillation, and AF can be more easily induced with medication.
Where are the most common sites of triggers that you see in patients?
I think the sites are similar sites. Left atrium is right around the mitral annulus, around the posterior atria, the base of the appendage, anterior septum around the area of low voltage where they typically are. The patient with sleep apnea many times do have this area. But the area that is really underappreciated is the right atrium. Crista terminalis, fossa ovalis, SVC, Eustachian ridge. These are the areas that you need to think about.
Yeah.
So I think we always knew about these areas, but how they contribute to each patient individually, I think the protocol is very helpful. If you do have a trigger, you have to remember that we can't say exactly what area in the heart specifically is responsible for these triggers. We are just reliant on the electrodes that we have in the heart and the resolution of those distribution. So if we did have a trigger, we will shock the patient on the isoprel back to sinus rhythm and move the catheters to zoom in on this area that look to be early relative to the intracardiac electrograms, but also early relative to the P-wave morphology. And then we'll repeat the same thing. So usually once the AF has occurred on isoprel and we shock the heart back to normal rhythm, and now we have catheters in locations closer to this area, usually within few seconds to a minute or two, AF will reoccur. And now we have many more electrodes in this area of the trigger. Hopefully, at this point, we'll have even better localization of this potential. Now, how do we know that this area is the right area? We always have to make sure that the area of earliest activation intracardially precedes the P-wave morphology. If it does not precede the P-wave morphology, we still need to zoom in more on this area. But most times it is. This area, still on isopropyl infusion, we're going to ablate this area, and we're going to create probably like a quarter-size lesions, 6-7 lesions in the same area of this trigger. And we're going to shock the heart again to sinus rhythm. And if that area was the area responsible for AFib, AF is not going to reoccur. So that validates the two things. It validates that that was indeed a trigger, and that ablation in this area removed this trigger. Once you have a trigger, it's many times going to be reproducible.
And then when you're outside the veins and you're ablating, how big of a target are you looking at to ablate?
Probably a diameter of like 2 centimeters or so,
Okay.
and then I repeat.
So just like a little cluster.
Yeah.
And then repeat it and make sure it's gone.
Actually, I'll make the ablation during AF after it's you induced.
Okay.
With the medication, make like few lesions around this diameter.
Sure.
Shock again, because I know that reproducibly I'm going to get AF
Yeah.
from the same location, and the end point would be that now you don't have any more AF. Yeah, and it's actually not very. As long as you nail down and you bracketed this area, it's pretty straightforward. I think identifying non-PV triggers is important to do not in all patients. It's important to do in patients that have risk factors to have non-PV triggers, and these will be patients with sleep apnea, patients with hypertrophic cardiomyopathy, women typically that have failed PVI before. But in all comers, in general, a good PVI is the way to start. We are here looking mostly on the patient that have recurrent episodes and the veins has been chronically isolated. So then you are left with two options. One is to do empiric ablation of multiple lines, but then the price is that you are going to encounter probably recurrent macro-reentrant circuits, or that you're going to use this approach, which is more physiologic, if you will, that you know that the veins are isolated and you're specifically looking to find areas that are responsible for initiating atrial fibrillation. We find this approach to be more specific. Actually, in a study that we did at BI, it looked like it was multi-center. It was with a few other centers. This approach resulted in less recurrence of atrial fibrillation in these specific patients, and specifically less recurrence of macro-reentrant circuits as a result of lines. So there is a role for this protocol in patients that have more than just lone AF. Patients again with sleep apnea, hypertrophic cardiomyopathy, and women. And in this patient, this protocol is a very good protocol to use, especially when the PVs are chronically isolated.
We do these procedures on general anesthesia.
Yeah.
Do you think that affects this as well? Because I would expect somewhat that you would have to give higher dosages of isoprel and other things.
Yeah, I think for triggers of AF, I don't know, because we haven't had the luxury of comparing patients awake versus patients on general anesthesia. We are now in the mode that we just do all patients under general anesthesia. But I think in patients that do have even AVNRT or some triggered arrhythmias, most times even under general anesthesia we can mimic these arrhythmias with higher doses of prel.
Of course.
Or if that doesn't work, many times, especially for PVCs, small boluses of epinephrine. I'm not sure if you've done it before or not, but 50 to 100 micrograms, really you can overcome the effect of sedation.